Hola, muy buenas noches. Bienvenidos a nuestra octava sesión mensual de la Asociación Mexicana de Endoscopia Gastrointestinal. Y a continuación les dar la palabra al doctor Ángel Andrés Reyes Dorantes, presidente de nuestra asociación.
Muchísimas gracias, doctora Zamorano. Bueno, pues no hay fecha que no se llegue, plazo que no se cumpla, y esta es la octava sesión de esta administración, es la última con la que cerramos este ciclo. Quisiera, antes de que empezáramos, decirles que estas sesiones tienen puntos para el consejo, para la recertificación, pero es muy importante que llenen el cuestionario previo y que luego hagan el cuestionario después de la sesión. Para dejar una oportunidad, todas las sesiones están en internet, las pueden ver a través de la página y pueden hacer las evaluaciones. Van a tener este mes de agosto para que todos los que por alguna razón no vieron alguna o no han cumplido las evaluaciones, lo hagan. Es muy importante para que ustedes obtengan la puntuación que el consejo nos da. Y esta sesión va a ser muy interesante, así es que tengo el gusto de presentarles al doctor Félix Telles, nuestro coordinador de las sesiones, y que nos va a presentar a los ponentes de esta noche.
Buenas noches a todos. Muchas gracias al doctor Ángel Reyes, a la doctora Yolanda. Y en esta última sesión de este año tenemos un invitado de lujo. El tema es sumamente interesante y actual. Es el drenaje endoscópico de la vesícula biliar. Para hablar de este tema, el doctor Douglas Adler, el cual es coeditor de la revista Gastrointestinal Endoscopy, es editor del tema de Gastroenterología New England, Journal of Medicine, y él está en Salt Lake City, donde es el director de endoscopía pancreatobiliar. Entonces tenemos todo un experto y posteriormente a su plática, el doctor Enrique Murcio y un servidor vamos a estar coordinando la parte de preguntas y respuestas con el doctor en vivo para que todos ustedes participen, y sin más preámbulo pues empezaremos con la plática del doctor Adler, al cual le damos la bienvenida. Adelante, doctor.
Okay, everybody. I want to thank Felix for inviting me to give this talk. And today I'm going to be talking about a topic that's very exciting to me, and that's endoscopic gallbladder drainage. And again, I'm Doug Adler. I'm a professor of medicine at the University of Utah in Salt Lake City, Utah. So the first thing I want to talk about is that, many people may have heard of endoscopic gallbladder drainage, but they may not have done it, or they don't know a lot about it. So it is an endoscopic alternative to percutaneous cholecystostomy in non-surgical candidates. It is not an alternative to cholecystectomy. And what I mean by that is patients who are surgical candidates should proceed to surgery and undergo a cholecystectomy. So endoscopic gallbladder drainage really is not competing with that. And again, if you have a bad gallbladder and you're a candidate for operation, you're much better off to have surgery. We see many non-surgical candidates at our hospital, and most of them have the same few problems because most people can safely undergo a cholecystectomy. Most of the non-surgical candidates we see have metastatic cancer, usually pancreatic cancer. That's the most common one. They may have heart failure or may be using a left ventricular assist device, and they're very high risk for surgery. Or they may have other unacceptable cardiac risks that the surgeons just don't feel like they can even tolerate a laparoscopic procedure. And the other most common one is if they have cirrhosis. Now, we've done endoscopic gallbladder drainage and cirrhosis many times, but there's some limitations to that I will talk about later in the talk. So you have two options for endoscopic gallbladder drainage, transampullary and transmural, and I'm going to talk about both of these in detail. They're very different, and they're done a different way, and they each have pros and cons. The transampullary approach is older. It's been around for about 10 years or more, And it's really just a modification of ERCP technique, whereas instead of cannulating the bile duct and putting your guide wire up in the proximal biliary tree, you put your guide wire in the cystic duct and you access the gallbladder. And instead of stenting the bile duct, you stent placed from the gallbladder through the cystic duct, through the common bile duct to the duodenum. So you're essentially providing transpapillary or transampullary transcystic drainage from the gallbladder to the duodenum. The nice thing about this is that the stent can be replaced as needed, taken out, or left in forever depending on the patient's need. With transmural drainage, it's very, very different. This is not an ERCP technique. It's performed by interventional endoscopic ultrasound, and it usually in 2019 involves placement of aluminum-opposing metal stents. You can do this with fully covered metal biliary stents or double pigtail plastic stents, but nobody really does that. It's like using a VCR when you could use a DVD player or watch Netflix. Nobody does it the old-fashioned way anymore. In transmural drainage, just like the name implies, the stent is placed through the gastric or the duodenal wall, and a direct connection or communication is made between the lumen of the GI tract and the gallbladder. And in contrast to transampullary drainage, where the stenting is often temporary or can be replaced, in transmural drainage, the stent is usually left in place forever as so-called destination therapy. So I'll focus on each of these for a little bit, and we'll talk about pros and cons. So I'll first start by talking about transampullary gallbladder drainage in detail. So this is what it looks like, and it sounds very, very simple in concept. And you can see here this is a fluoroscopic image taken during one of my ERCPs, and here's the duodenoscope in the second duodenum. This is how I do the fluoro. It may be a little bit backwards from the way you're used to looking. And you can see we've accessed the bile duct with a sphincteratome, and right here is the cystic duct origin, and you can see my guide wire goes up through the cystic duct, and it goes into the gallbladder. You can see some stones and sludge in that gallbladder manifesting as filling defects. This is another image from a different case that shows that you can tell here we had a more difficult time, and here we had to use a cholangioscope to find the cystic duct opening. Sometimes you get lucky, and the guide wire goes in very, very easily, and you're done in 5 minutes. Other times it can be a real struggle to get the guide wire in the gallbladder. And here in this case you can see we tried for a long time with the guide wire and the sphincteratome, and we could not access the gallbladder because we couldn't find the cystic duct orifice. And we had to use a cholangioscope to find the very small orifice and to target the wire in a three-dimensional way to go in that one little tiny opening. And then whether it's easy or hard to get into the gallbladder, this is what it often looks like afterwards. So again, you can see the case is over now. Here's my duodenoscope, and here's a double pigtail. One pigtail is in the duodenum, up through the bile duct, up through the cystic duct, and one pigtail in the gallbladder. And ideally, you want to use a double pigtail stent that has multiple side holes to maximize drainage. It's very uncommon for these double pigtail stents to clog if they have side holes. And obviously, clogging of the stent is something you want to avoid. So there is a limited literature on transampullary gallbladder drainage. This is one study by Lino that was in Endoscopy International Open just in 2018, and they compared transampullary gallbladder drainage to percutaneous gallbladder drainage in 78 patients. 33 patients underwent transampullary drainage, 42 patients underwent percutaneous drainage. So they had a 77% success rate with transampullary drainage, which I think is a little lower than average, but probably not that far from average. And they had a 100% success rate with percutaneous drainage. And again, the radiologists have some advantages over us because they're usually going for a large gallbladder target, whereas our target is really not the gallbladder, but it's the cystic duct. So we're trying to get into a much smaller space. There were no differences in adverse events, and endoscopically treated patients had a significantly shorter hospitalization. So it sounds easy, right? I mean, if you're used to doing ERCP and you're a good endoscopist and you're comfortable with your guide wire skills, it seems like this should be very easy to do. But I will tell you that in reality, sometimes it can be extremely challenging. Sometimes I joke that the case is either going to be 10 minutes or 90 minutes, but I don't know. It'll be one or the other. Challenges to transampullary gallbladder drainage really come from the technical issues of really accessing the gallbladder in an ERCP manner. Sometimes, like I've shown, it can be very difficult to get the guide wire even into the cystic duct. Sometimes you may get into the cystic duct, but the valves of Heister may make it difficult to get the guide wire all the way through the cystic duct and into the gallbladder. Many of these patients have cholecystitis. That's why you're being called to drain their gallbladder in the first place. And in many of these patients, the cystic duct may be obstructed. And sometimes you can force a guide wire through an obstructed cystic duct, but sometimes you can't. The cystic duct may be too narrow to allow even a small stent, right? So I don't know if you noticed, but in the picture I showed just a few minutes ago, that double pigtail stent was 7 French. And sometimes the cystic duct is too narrow or too swollen or too blocked to even allow a 7 French stent. The other thing, too, is, as you recall, the cystic duct is often very tortuous. It may have spirals or loops, and it may not allow a stent to go across. And part of the problem is that these are factors that you can't predict before the procedure. You can look at the patient's ultrasound or CAT scan, but none of that gives you enough detail of information about the cystic duct to know that you'll be able to succeed or not. So you just really have to commit to trying, and you also have to commit to trying hard, meaning if it doesn't go easy and you don't have success in the first 5 minutes, you don't give up. You have to use other techniques like I've shown. You may have to use different catheters, different wires, a cholangioscope, right? You've got to be willing to hang in there, as we say in America, and do what needs to be done to get the stent in the bile duct. So, transampullary drainage, it does have some advantages over transmural gallbladder drainage, and that's in a couple of different settings. And for example, transmural drainage really has to be done in somebody who is not anticoagulated. But if the patient is on anticoagulation and cannot stop, for example, if they're on a left ventricular assist device, maybe transampullary gallbladder drainage is a better option for them. You can look at a CAT scan before the procedure and see if the gallbladder is adjacent to the stomach or the small bowel if you're thinking about doing a transmural drainage, but sometimes it's not. And if the gallbladder is several centimeters away from the stomach or the small bowel, you can't do a transmural gallbladder drainage with the existing technology, right? So again, this is a reason for transampullary drainage. I did mention before that we've done some transmural drainage in patients with cirrhosis, but if the patient has significant ascites, either from cirrhosis or from malignancy, transmural drainage is not a good option, and these patients should maybe have transampullary drainage. And sometimes if you think the patient may become a surgical candidate in the future, right? Some people are a bad surgical candidate at one time because of other medical issues, but they may be a good surgical candidate in weeks or months to come. Maybe it's better if you think that the gallbladder will eventually come out, maybe to put a transampullary stent in. And I'll talk more about that later in the talk. The other thing, too, is, like I said, with very rare exception, transmural drainage is permanent. And if the patient wants an option that's reversible, transampullary drainage might be better. So let's shift gears now and talk about transmural gallbladder drainage. This is one of my most favorite things to do. I try to do this if I can as much as possible. It's very exciting and it's very rewarding for the patient and the doctor because they really get better very, very quickly. So in 2019, we're pretty much only doing this with lumen-opposing metal stents. In the United States, we have one lumen-opposing metal stent on the market. We have the Axios stent. In Europe and Asia, there's the Spaxis stent and the so-called Nagy stent. There's different lumen-opposing metal stents available around the world. I'm not sure which ones you have access to in Mexico. So, one thing that we learned from lumen-opposing metal stents is that although they, at least in the United States, they have been approved for pretty much just drainage of pancreatic fluid collections, either pseudocysts or walled-off necrosis that are symptomatic and need endoscopic access and debridement and drainage, we have expanded the use of these lumen-opposing metal stents greatly, and I will tell you that I use a very large volume of lumen-opposing metal stents, but only about half are on label. About the other 50%, I'm doing biliary drainage, gallbladder drainage, treating strictures, making enteroenteric anastomoses, like for edge procedures. We're doing all these other things routinely. And again, these are not approved, but I think that most people in America have not waited for approval, and they're just doing these procedures because they're so successful. So this is sort of a cartoon drawing from a paper by Mori, just sort of showing what EOS-guided transmural drainage looks like. And here you can see the endoscope is making a connection between the duodenal bulb and the gallbladder and deploying a LAMS over a wire. It's interesting that they show a wire in this picture, and I'll talk about whether you do or don't need a wire. So this is what a representative case looks like, and you can see this is a very large distended gallbladder with a very thick gallbladder wall. This patient had acute cholecystitis in the setting of malignancy and was not felt to be a candidate for surgical cholecystectomy. The patient was unenthusiastic about a percutaneous drain that he would probably have in for the rest of his life, so we were asked to evaluate this patient, and he was excited about the possibility of an internal option. So now you can see I've lined up, and I'm using a 20 millimeter Axios, and I just used the hot Axios, and I've just burned through the duodenum into the gallbladder. And one thing you'll notice here is there's no guide wire. I'm not using a guide wire. I started off using a guide wire, and I really don't anymore. And I'm also not using fluoroscopy. I started off using fluoroscopy, and I really don't. And you can see I've just deployed the distal flange of the stent. So I went from using guide wires and fluoroscopy and endoscopic ultrasound to really just using endoscopic ultrasound alone. Once you get comfortable with this, you don't need the other technologies in most patients. And now you can see I've switched to the endoscopic view. You can see the catheter going through. You can see there's a little bit of a burn on the mucosa. And as the stent starts to deploy, you can see some bile is already coming out. And I usually do the proximal flange deploy under endoscopic guidance alone. I don't really find the ultrasound helpful at this point, but some people do. And you see we're getting beautiful drainage of bile there. So that's exactly what you want to see. And then this is what it looks like a few minutes later. And you can see we're in the duodenal bulb. This is the apex of the duodenum off with the root to the second duodenum. And here's the stent pointing to the gallbladder. And you know, if you do a lot of these, you learn that the gallbladder can be anywhere. The gallbladder can be in the superior aspect of the bulb, in the medial aspect, believe it or not, in the inferior aspect. You have to be prepared to put the stent into the gallbladder wherever the gallbladder is, right? The goal is to make a connection, and sometimes the scope is in a very unusual position. But if you can see the gallbladder and you have a very close gallbladder to the stomach or the duodenum, in my opinion, with rare exception, it doesn't really matter where you make the connection as long as the gallbladder is close. So I've put these stents in everywhere in the stomach and the duodenum, and the patient does just fine. So you don't really worry about how it looks. And this is about a week later in this same patient. We brought him back just to see how he was doing. And you can see I've taken this photograph with a regular upper endoscope, and we're just looking directly into the gallbladder. That's the gallbladder mucosa. And you can see it's a very wide opening. This is a 20 millimeter lumen-opposing metal stent, and that's more than big enough for the upper endoscope to drive through, and many times we drive into the gallbladder to look around. You can see the cystic duct from the inside, and you can remove stones if you need to. And for example, this is a patient who had a bunch of stones in his gallbladder, and we brought him back about a week after his stent was placed and his cholecystitis had resolved, but we just cleared out his gallbladder of all of his stones. And you can see we're just using a Roth net to pull those stones out one at a time, and that's actually a lot of fun to do. So there is some data on EUS-guided gallbladder drainage that has come out over the years. Not a tremendous amount, but there's a fair bit of papers now. And this is from a Japanese study looking at multiple approaches to gallbladder drainage. And they compared different types of stents, plastic stents, self-expanding metal biliary stents, and lumen-opposing metal stents. And you can see the success rates are similar, very similar across the board. But if you look at the adverse event rate, LAMS had the lowest adverse event rate in this study of about 10%. Babu Mohan and I published this meta-analysis in the Endoscopic Ultrasound Journal earlier this year, and it's called Adverse Events with Lumen-Opposing Metal Stents and Endoscopic Gallbladder Drainage, a Systematic Review and Meta-Analysis. And, you know, our overall rate of adverse events that we found was 12.7%. So that's a real number. So you have to recognize that transmural gallbladder drainage with a lumen-opposing metal stent is a relatively high-risk procedure in a very sick patient. 12%, almost 13% overall adverse event rate. And you can see bleeding, bile leak, stent clogging, perforation, migration, cholecystitis, death. Right? These are not insignificant adverse events. Now, these are very sick patients, and they're often willing to accept a little bit of increased risk because they often have very few options, or they are facing a lifetime of a tube coming out of their side. So many patients will risk endoscopic ultrasound approaches. And some of these things you can treat, bleeding, bile leak, stent clogging, stent migration. These are things that you can often fix yourself. So how do lumen-opposing metal stents compare to percutaneous cholecystostomy tubes? Shaimarani published a paper about 2 years ago looking at 90 patients, half who had EUS-guided gallbladder drainage with LAMS, half of whom had a percutaneous drain. It's important to note that in the ultrasound group, 98% technical success versus 100%, 96% clinical success versus 91%. And there were fewer reinterventions, lower pain score, and shorter hospital length of stay in the ultrasound group. And of note, their complication rate of 11% was almost exactly the same as what we found in our study. Amy Tyberg looked at a group of 155 patients, about 3/4 of which had a percutaneous drain. And when they looked at the EUS drainage, they had 95% technical success versus 99% in the tube group, 95% clinical success versus 86% in the tube group, no difference in adverse event or readmissions, but the endoscopic group needed significantly fewer repeat interventions. So I said earlier that I thought that, you know, most of the time you would put a lumen-opposing metal stent in if you thought the patient was never going to go to surgery. And in my experience, it is very rare for patients to go to surgery after endoscopic gallbladder drainage if it's transmural. This is a small multi-center study looking at cholecystectomy after LAMS drainage or percutaneous cholecystostomy. And they found that it was actually about as successful. So what this meant was that there was similar technical success and adverse event rates, whether the patient had a prior percutaneous tube or a endoscopic gallbladder drain. And the gallbladder surgeries were successful in 100% of patients. Again, it's a very small number of patients in the EUS group, only 13. But what it shows you that endoscopic transmural drainage does not preclude surgical cholecystectomy down the road if the patient becomes a better surgical candidate. And in this study, there were no differences in the rate of conversion from laparoscopic to open cholecystectomy, post-surgical morbidity, or adverse events, although the surgical time was shorter in patients who had endoscopic drainage, which is interesting. I would have thought it would have been the opposite. So in conclusion, I would say that endoscopic gallbladder drainage is very safe and effective overall, and both approaches are alternatives to percutaneous cholecystostomy. So if you do ERCP, you can do this. If you do EUS, you can do this. And if you do ERCP and EUS, you have both options at your disposal. I don't think that either approach is perfect in every patient, and you've got to individualize care based on the patient's anatomy and your expertise and what your surgeons feel comfortable with. And I think that one of the most difficult things in this whole game, I didn't really talk about this, is that the surgeons must become aware that you are willing to do these cases. You know, classically, when surgeons say that a patient is not a surgical candidate for cholecystectomy, the patient is automatically sent to interventional radiology to put a percutaneous drain in. And if they don't know that you are available and willing to do these cases, which are often emergent, you will never do them. But if you are able to insert yourself in that algorithm, right, so that the surgeon realizes that they should call you, then you can start to get these cases. As the surgeons see that you can do endoscopic gallbladder drainage by either a transampullary or a transmural approach, you know, as they see your successes mount, they will start to call you more and more. So, you know, even doing one or two of these can really, really increase your numbers. So, but again, if they don't know that you can do this or that you're interested or available or you're willing to take the risk on these technically challenging cases, they will never call you. So again, I will stop there, but remember, I would say that if you're interested in these procedures, you certainly should be doing them. They're very safe and effective. And again, I want to thank everyone for listening, and I want to thank Felix for the opportunity to give this talk. It's a great honor, and thank you very much.
¿Qué tal? Buenas noches a todos nuevamente. Ahorita vamos a hacer los ajustes para poder entrar a la ronda de preguntas y respuestas. Le doy la bienvenida al doctor Enrique Murcio. Él es adscrito del Centro Médico Nacional Siglo XXI, el endosonografista muy conocido por todos, y pues con él vamos a estar en esta parte de la pregunta de preguntas y respuestas. Vamos a estar también interactuando con los que estén conectados en línea y tengan alguna pregunta, por favor mándenla, y ahorita nos van a hacer llegar el aparatito para que podamos ir leyendo y transmitiendo las preguntas al doctor Douglas Adler. Justo ahorita estamos haciendo los arreglos para terminar esta conexión. Y Enrique, pues, ¿qué te pareció la plática?
Bueno, creo que es una plática que resume muy fácil sobre lo que dice la evidencia en relación a las ventajas que ha demostrado tener el drenaje endoscópico de la vesícula. Y bueno, la forma convencional o tradicional, que era a través de la papila, sin duda que pues siempre implicaba el tener que entrar al cístico, lo cual técnicamente lleva más tiempo, ¿no? Y dispositivos nuevos como el sistema de J-Axios, sin duda que lo hacen más sencillo. Platicábamos un poco sobre otra enorme ventaja, que ya no se requiere la aguja para tener que acceder a la vesícula, sino que el mismo cauterio que tiene el sistema J-Axios permite que en un solo movimiento se pueda realizar la punción, la dilatación y luego la liberación del stent. Entonces, bueno, pues yo creo que en esta plática nos han mostrado evidencia muy a favor para que este procedimiento siga creciendo y que muy probablemente pues la evidencia lo vuelva el estándar de oro de tratamiento de los pacientes no candidatos a cirugía con colecistitis aguda, que eso es creo que un mensaje clave de pacientes que no son operables, ¿no?
Sin duda, yo creo que conforme vaya pasando el tiempo, parece que la evidencia nos va a llevar a que el drenaje guiado por ultrasonido de la vesícula biliar pueda ser considerado como de elección sobre el drenaje percutáneo, en pacientes no candidatos a cirugía o que no van a ser candidatos a cirugía. Personalmente digo, ahorita vamos a preguntarle al doctor Adler, pero en mi centro todavía es complicado que los cirujanos acepten un drenaje temporal de la vesícula transmural, es decir, si un paciente va a ser candidato a operarse, es difícil que los cirujanos acepten, aun cuando la poca evidencia que hay pues pareciera ir a favor de esto. Y llama la atención también algo que me gustó mucho la plática del doctor Adler, que no dejó de lado el drenaje de la vesícula vía transpapilar. Es decir, los endoscopistas tenemos la oportunidad de también drenar la vesícula, no nada más vía transmural, sino también vía transpapilar, sobre todo en aquellos pacientes que pudieran tener problemas de coagulación, pudiera ser una opción, aunque evidentemente sí mucho más complicada que una CEPRE tradicional. No sé si ya estamos conectados. Ahorita estamos tratando de tener esta nueva conexión con el doctor Adler, pero bueno, este es un camino yo creo importante, y decía yo creo que muy bien el doctor Adler en su diapositiva final que los endoscopistas tenemos la tarea, probablemente la obligación de ponernos nosotros mismos en el algoritmo. Es decir, no es labor del cirujano pensar que la endoscopía es una opción para drenar la vesícula de alguno de los dos métodos, transmural o transpapilar, sino más bien nuestra de irnos a poner en el mapa y decirles que nosotros podemos hacer eso, que lo podemos hacer bien, que funciona y que ofrece ventajas sobre el drenaje percutáneo. No sé tu experiencia ahí en el siglo XXI, pero acá con nosotros sí es cierto que los cirujanos no piensan necesariamente en los endoscopistas para drenar estos pacientes de la vesícula.
Bueno, yo creo que un punto clave que mencionó el doctor Adler en su plática es justamente eso, ¿no? El acercarse probablemente con el radiólogo intervencionista y antes que él con el cirujano también, para decirles lo que está demostrado como beneficio de este procedimiento. Y bueno, haciendo uso del refrán de que no solo hay que poner el huevo, sino también cacarearlo, en sí, en el Instituto Mexicano del Seguro Social, en el centro donde yo estoy, pues he encontrado más eco en la gente joven, pero cuando participamos en foros como multidisciplinarios y ellos empiezan a ver los números de algunos procedimientos en donde ellos no quieren o no pueden entrar, y sin duda que empiezan a tomarlo en cuenta uno pues como una opción, ¿no? Tenemos un buen radiólogo intervencionista, sin duda también, pero creo que habrá candidatos, como se mencionó en la plática, en donde el drenaje por ultrasonido endoscópico sea superior y pueda volverse el estándar de tratamiento de estos pacientes, ¿no?
Sí, yo creo que la evidencia poco a poco nos va llevando hacia allá, es decir, el ultrasonido endoscópico ha venido a posicionarse en la terapéutica del drenaje de algunas colecciones intraabdominales, pseudoquistes, necrosis, colecciones posquirúrgicas, y ha venido a demostrar que en manos expertas es superior en muchos aspectos al drenaje percutáneo, sin que este deje de tener su lugar. Pero yo creo que en el caso de la vesícula, precisamente también algo parecido irá ocurriendo. Una situación importante en esto de la vesícula probablemente sea la necesidad de una prótesis de aposición luminal y con los costos que esto conlleva, pero parece interesante lo que tú mencionas de que no necesariamente se requiere una aguja, una guía, un dilatador, todo esto que te ahorras, probablemente los costos los compensen. No sé, ustedes en el siglo XXI que les sea más fácil si tener todos estos accesorios o tener una Axios, por ejemplo, porque para el que lo hace, sin duda es mucho mejor contar con un accesorio como el Axios que trae todo en uno, o para no hacer anuncios, una prótesis por aposición que tenga todo en uno y que en 2-3 minutos hayas ya podido hacer el drenaje versus todo el procedimiento que requiere cuando tiene los accesorios de manera separada.
Digo, posiblemente ese sea un argumento a favor de solicitar que ese insumo pueda estar como autorizado. Nosotros tenemos un sistema administrativo muy en particular, pero bueno, creo que el costo efectivamente termina siendo aceptable y bajo en comparación a pretender hacerlo de la forma convencional, ¿no? Entonces, mientras logramos tener la comunicación con el doctor Adler. Dr. Adler, good night. Can you hear us?
Hello?
Good night, Dr. Adler. This is Felix Telles. How are you tonight?
I'm good.
Thank you so much for being here with us. Here, let me introduce you, Dr. Enrique Murcio and me, Felix Telles. So we have a lot of questions for you about your very, very interesting talk.
Okay, sounds good.
Okay, so hello, Dr. Adler. This is Enrique Murcio, and I'm going to start with so many questions that we have from the audience. So one of the main questions is about what's the management after you do a EUS gallbladder drainage with the fistula that is formed? How long does the lamps stay in place? Do you take it out? How do you do it?
So can you hear me okay?
Yes, we can hear you.
So usually when you're doing EUS guided gallbladder drainage, it is permanent. So there is no plan to remove the stent.
Okay, and your surgeons in your center, what say about that? I was talking with Enrique that in my center particularly, the surgeons are very concerned about the technical difficulties to do the cholecystectomy, laparoscopic cholecystectomy after this drainage with the lamps.
Right. So two things. The first thing is that most of the time when you are called to do an endoscopic ultrasound guided gallbladder drainage, the surgeons have already declined to operate. And then there's a limited amount of literature on gallbladder surgery after endoscopic drainage, and it is possible and it is safe. But the data is very limited.
Dr. Adler, what's your opinion about a pigtail stent through the lamps? Do you think it's useful to avoid migration? You show us numbers of low rate migration from the lamps. So what do you think about putting through pigtail stents inside the lamps?
So I often put a pigtail stent in, sometimes not on the first procedure. A lot of times on the first procedure, the patient is very, very sick and unstable. So your goal is just to put the Axio stent in, decompress them, and then get out. And then I will bring them back a few days later, drive through the stent into the gallbladder, remove any stones, and then put a double pigtail through the Axios.
And do you do that in a regular manner? I mean, always do that? Did you hear me, Dr. Adler?
Can you say that again?
Yes. I was asking about if you do always that. I mean, first leave only the lamps and few days later go in again to put the plastic stent and to go out with the biliary stone.
Right, yeah, no, I'll go back a few days later to look at the patient, make sure the stent is okay. And like I said, I usually put a double pigtail in on the second procedure, but you can put it in on the first procedure if you want.
Okay, I have here a question. Do you hear me? Dr. Adler, do you hear me? I'm not
Yes.
sure. Yes? Okay, I have a question that is repeatedly here with the public here in Mexico. They ask two things. One is the time of the procedure. How much time takes you to do the complete procedure?
The procedure is very fast. If you're doing an axios in the gallbladder, it's usually less than 15 minutes.
15 minutes?
It's very
Less than
fast.
10 minutes.
Muy rápido.
Yeah, I'm agree. And another question, more than once here in the public is, they ask if you think that is not too aggressive to create a fistula between the duodenum and the gallbladder in a critical ill patient.
I mean, I think that it's definitely aggressive, but they need it. They're very sick. They're not surgical candidates. And their other option is a percutaneous drain, which is terrible. So I agree with you. It's very risky and aggressive, but most patients are willing to do it.
Yeah, I'm agreeing with you. Personally, I do that. I think that the advantage in quality of life for the patient is important, mainly in critical ill patients. I mean, they are, majority of my patients with this procedure are patients with many other illness of certain age, so they are not candidates to surgery.
I mean, migration is a risk, but it's relatively low. I worry more about perforation and bile leak.
Bile leak. And with the, do you have any preference about one of the kinds of lamps?
In the United States, we only have one LAMS, and that's Axios. Outside of the U.S., there's the Nagi and the Spaxis. So in America, we only have experience with one.
Okay. What about the size of the lamps? What do you prefer? 10, 15, 20?
Usually 15 or 20. So I never use a small one. I like the larger sizes.
And do you have any experience with complications related to the size? I mean, 15 versus 20? 20
I had one patient with a 15 millimeter Axios who his fever went away and his pain went away, and then 24 hours later, he got a fever again and bad pain, and he had food impacted in the stent and food in the gallbladder. And then we were able to clear the food out of the stent, and he felt better, but he did have food in his gallbladder.
Another question from the audience is that you told us about a gastric or transduodenal access, that you can perform the one that you have a good endosonographic view. But technically, do you think transduodenal is easier than a transgastric?
You know, when you start doing this, you feel safer in the stomach because the stomach is so sick. But I think a lot of people, as they get experience, find that the duodenum is actually a better place because the duodenum gives you a much better view of the gallbladder. And again, it is a thinner wall to go through the duodenum than the stomach. But I think once you do a couple in the duodenum, you realize that it's actually much better and easier. The endoscope is also in a much better position in the duodenum than in the stomach because there's much less movement when you're in the duodenum.
Another question is about what do you think about performing laparoscopic cholecystostomy versus the EUS gallbladder drainage?
You know, I mean, it's a good question. In the United States, the laparoscopic cholecystostomy is extremely uncommon. So, I mean, I think it's a good option if your surgeons are willing to do it. Here, they will not do it. Here, they will do cholecystectomy or nothing. I think, too, is if they were going to do surgery in the first place, they would just take the gallbladder out.
Yes, I'm agree. If a patient is good candidate for surgery, I think that the election must be surgical laparoscopic.
Right.
Of course. And what do you think? If you were on vacations in some paradise in the Pacific, and I hope not, but if you have a acute cholecystitis, what do you prefer, percutaneous or US guided drainage of your gallbladder? What do you prefer?
Right. So if it's me, I'm young and healthy. And I would probably ultimately have a gallbladder surgery, so a percutaneous cholecystostomy would be better. But if the patient was older and had more comorbidities, much better off for endoscopic drainage. But again, if the patient is a candidate for surgery, surgery is the best treatment.
But okay, let me suppose that when you are in the age that you are not a candidate for surgery, if you were here in Mexico on vacation, what do you prefer? Percutaneous cholecystectomy or US drainage of your gallbladder?
Yeah, if I was not a surgical candidate, then endoscopic drainage.
Oh, I was thinking that maybe your answer was about availability of the person, because I think that the problem with US gallbladder drainage must be if you have a endosonographer that can do that.
I'm having a hard time hearing.
Okay. You don't hear me?
Oh, yeah, it's a little hard to hear.
Okay. Again, what do you think about the necessity to have a prepared person to do that? I mean, no, it's not so common here in Mexico to have a person that can do these kind of procedures.
Right. So, I mean, if you are comfortable doing endoscopic ultrasound, you can do endoscopic ultrasound gallbladder drainage. I will tell you, one of the dirty secrets is it's really not that hard. Technically, it's very easy, but you have to be willing to take the risk.
Yes, I'm agree with that. I think that if you are a person that can do pseudocyst drainage by US, I think that the gallbladder is very similar.
So, Dr. Adler, you told us that the lamps stays in place because these patients are usually non-surgery candidates.
Yes.
So once you put lamps in place, what do you usually do with the stones? Do you always try to take it out after what time? And if you have a big size stone, do you use like an endoscopic, like a lithotripsy catheter or something like that? What do you do about the stones once the fistula is mature?
So you can either try to remove the stones, and it's often technically not very hard, and it's actually a lot of fun. But if you don't want to take the stones out, you could just leave them, and as long as there is adequate gallbladder drainage, it doesn't really matter. I think patients like it if you remove the stones. So we often do it because the patients like it and they feel better emotionally. And you can remove the stones with a Roth net or a stone basket very easily.
And how frequent is that you need something else like lithotripsy?
Say that again?
It's frequent that you need to use cholangioscopy with laser, for example, to do lithotripsy in this kind of patients?
Not very common.
Have you used it? Have you been using this?
I have done it, but rarely.
So, it seems like everybody is very clear with your talk, Doc.
You should all try it.
Yes, all the people here have the same question that we did it with you, but you have a lot of message here with congratulations. Everybody is happy with your talk. I mean, it was very difficult topic, and I think that is very clear now for us, the actual position of the endoscopic drainage of the gallbladder in patients not candidates to surgical procedure.
It's very hard to hear.
Oh, sorry, sir. Let me, you hear me better here?
Yeah, if you could talk closer to the microphone.
Okay.
There's an echo.
Oh, sorry. Oh, we want to say thank you. Was a very nice talk. We all here very happy. Was very nice lecture. So we really appreciate your time, Doc. We know that you are a very busy person. So we want to say thank you.
Thank you.
Oh, thank you, Dr. Adler. It was a really nice talk, very instructive, very didactic. So thank you very much for all what you teach us today.
Thank you, guys. Buenas noches.
Buenas noches. See you soon.
Bye.
Bye. Bueno, creo que con esta conferencia del doctor Adler, muy instructiva, de un procedimiento muy interesante, terminamos este ciclo de sesiones, así es que le damos el agradecimiento a nuestros expertos nacionales, el doctor Enrique Murcio, Félix Telles, y vamos a dar algunos anuncios parroquiales, le llamamos aquí.
Bueno, buenas noches nuevamente. Les comunico que está disponible en la página web el micrositio de la próxima reunión nacional que se llevará a cabo del 14 al 18 de septiembre en el Poliforum León, donde encontrarán acerca información del registro, hospedaje y todo el programa académico y currículum de los profesores internacionales y nacionales invitados. También contaremos con talleres de modelos biológicos, taller de manometría, taller de cápsula. También un taller innovador es el de detección de lesiones tempranas y un taller de limpieza y reprocesamiento de endoscopios. Estos talleres están dirigidos tanto para el personal médico como para también técnicos y enfermeras. Y por favor les pedimos que se inscriban con anticipación. Y para los médicos residentes tendremos transportación terrestre de Ciudad de México León, León Ciudad de México, y para esto tienen que inscribirse antes para que tengan acceso a este transporte. Para los asistentes en endoscopía tendremos descuentos en la inscripción al curso precongreso, congreso y talleres. Por favor, no olviden realizar las evaluaciones mensuales para que tengan su constancia con valor de 8 puntos que otorga el Consejo Mexicano de Gastroenterología, y la plataforma se encontrará accesible hasta el día 31 de agosto. También les hacemos una atenta invitación al segundo Congreso Mundial de Endoscopia Gastrointestinal Endo 2020, que se llevará a cabo del 7 al 10 de marzo en Río de Janeiro. Entonces, tienes hasta el 15 de agosto para inscribirte con un descuento muy atractivo. Y finalmente, otro evento académico que tenemos en forma conjunta con la Asociación Mexicana de Gastroenterología y Hepatología es el 27 y 28 de septiembre en San Cristóbal de las Casas, donde tendremos un taller de manejo de hemorragia digestiva, y por favor les pedimos que se inscriban con oportunidad. Pues muchas gracias por la oportunidad de trabajar en esta mesa directiva en esta última sesión. Y bueno, le cedo la palabra al doctor Reyes y nos vemos en León.
Pues no me queda más que agradecerles, primero a todos ustedes, su participación, su interés. Hoy tuvimos 140 conectados en tiempo real, conexiones desde otros países, tuvimos de varios países de Centroamérica, de Sudamérica, así es que es muy, muy emotivo y es la razón de ser de estas sesiones. Quiero también agradecerles muy especialmente a los coordinadores de todo este ciclo de sesiones, al doctor Félix Telles, al doctor Guido Grajales y a la doctora Ángela Saúl, su trabajo, su entusiasmo. Quiero agradecerles a todo el equipo técnico, porque hacer la transmisión, enlazar a los profesores, conectarse, estar en tiempo real haciendo los detalles de que tengamos un audio, que tengamos un video, que tengamos la traducción. Desde luego a las coordinadores, a la doctora Xochiquetzal y a la doctora Yoli Zamorano, que también con entusiasmo estaban aquí y nos daban todos los anuncios, y desde luego que al equipo de soporte de la AMEG, a Flor, a Bernardo, a Eli, a Verónica, a Mayra, al señor Mena, que también es muy importante su trabajo para que todo esto se realice. Este es un trabajo de equipo, solamente pues me queda el privilegio y el honor de ser un poquito el coordinador, el director de la orquesta, pero es un trabajo de mucha gente vigilando todos estos detalles. Es que esperamos que esto haya sido didáctico para ustedes, que les haya parecido interesante, que hayan aprendido mucho y que obtengan sus puntos para la certificación. Acuérdense, contesten sus evaluaciones previas, posteriores. Estas sesiones quedan grabadas, pero para que obtengan los puntos tienen que verlas antes de que se termine este mes de agosto del 2019. Y bueno, pues ya vemos todos los eventos académicos que tenemos por delante. Los esperamos en todos ellos. Creo que vernos, estrecharnos la mano, desearnos mucho éxito y aprender juntos es la misión de la AMEG, y todos trabajamos con esa intención. Muchísimas gracias, muy buenas noches y que la pasen muy, muy bien. Nos vemos pronto.